Good evening, explorers. Thank you for joining us on the Columbus Connects Coronavirus Town Hall meeting. Before we begin tonight, let's start like
we're not. So hold on.
Okay. When do I know we're starting over? When it goes to the corona to that?
Yes.
Okay. So you're gonna let me know when we're about to start, Omar? Give me a countdown.
When you see this screen go off, we're live.
Okay. All right.
It takes me here. You should give me 60 here.
It pops up. All right. Good evening, Columbus. Thank you for joining us to the Columbus Connects Coronavirus Town Hall meeting. Before we begin tonight, let's start like we start everything at Columbus and start with a prayer. Here with us tonight is Mr. Jerry Gonzalez, the head of our campus ministry, to lead us in a prayer. Please keep in your prayers for one of our own from the class of 1982. Mr. Freddie Valderrama passed away on Tuesday morning from a heart attack unrelated to the coronavirus. Jerry?
Good evening, Columbus family. Despite all the troubles and all the struggles, as a people of faith, we still say happy Easter. So on behalf of all of us at Columbus, a happy Easter to all of you. And we pray in the name of the Father and of the Son and of the Holy Spirit. Amen. Let us pray. St. Paul reminds us in his letter to the Philippians, I have the strength to face all conditions by the power that Christ gives me. Lord, this first week of Easter, we thank you for your presence and we thank you for your grace. As we experience the realities of COVID-19, we pray for the repose of the souls of those that are no longer with us due to coronavirus and for other reasons. Grant comfort and strength to those physically battling this virus. We pray for their families and friends, for those facing stress and anxiety. We pray for those no longer employed or whose work hours have decreased. We pray for business owners whose doors have closed. And we pray for those attempting to keep their business doors open. For students, families, and educators throughout the world. We pray in a special way for Columbus students, families, alumni, staff, faculty, administrators, and Marist brothers. Thank you for the gift of faith and science. Bless our panelists and bless the medical community, law enforcement personnel, faith leaders, and all that are serving others. As Marist, we ask this through the intercession of Mary, our good mother. Amen. Saint Martin Champagne, pray for us. Mary, our good mother, pray for us. And let us remember to pray for each other. Be assured of our prayers for you and your loved ones, and please remember us in your prayers. In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Thank you, Jerry. With us tonight are 4 doctors with 92 years of experience between them. During the meeting, if you have any questions, please hit the chat button on the bottom and type in your question. We will try to get to all of your questions. Please put your name and the year that you graduated from Columbus, and to which doctor you want the question addressed to. Thank you, and let's begin. Let me introduce our doctors. First, we have Dr. Rosendo Bebo Collazo. Dr. Collazo is from the class of 78. He is a board-certified internal medicine doctor. He has been practicing for 31 years and is a member of the Baptist Health and Medical Group. We have his wife, Dr. Lorraine Dowdy Collazo. She's an alumni. Between them, they've had 3 boys go through Columbus. She is a board-certified infectious disease specialist for 33 years, and she is currently at Baptist Hospital in Jackson South Community Hospital. Then we have from the class of 1998, Dr. Jerry Capote. He is a board-certified pulmonary critical care doctor. He has 10 years experience and practices at Jackson Health and Jackson North. And then lastly, we have Dr. Fernando Mendoza from the class of 87. He is also a parent. He has a son who was a sophomore at Columbus. He is a board certified in pediatric emergency and pediatrics. He has 18 years of experience and is the medical director at Baptist Children's Emergency Center, West Kendall Pediatric Emergency Department, and he is also the chief of staff of pediatrics at Baptist Children's Hospital. Now let's get to our questions. Question number 1 is for Dr. Lorraine Collazo. Dr. Lorraine, what is COVID-19 and what is the virus that causes it and how did it spread?
Well, coronavirus is part of a family of viruses, some of which are quite common and are well known to us in the medical community. Unfortunately, this particular coronavirus, which carries its name because it has, it's a circular virus with kind of a spiky, knobby outer coating, which it's been all over the news, so anyone can take a look at the picture. The difference between all the coronaviruses that we've experienced before and this coronavirus is that it is new. It's actually called novel coronavirus 19 because it emerged in China in 2019. We know more about it as time goes on, but initially it's spread by droplet, meaning coughing, sneezing. It may also be spread by finer particles, airborne, that may be generated by things like using an aerosol machine, if you have asthma. So that's the primary way that it's transmitted. I know that people have been concerned. There's a lot of news that suggests that it can be transmitted in other ways, but primarily it's through cough, sneeze, and touching your hands to your face when your hands are contaminated with fluids from coughing or sneezing.
Thank you. The next question is for Dr. Bebo Collazo. Bebo, what symptoms should we be looking for if we suspect that we have the coronavirus?
Well, primarily, the most common symptom is fever, and fever represents probably about 80% to well over 90% of the symptoms. Fever is very variable. It could be low-grade fever, and it could be quite high as well. The caveat there is that 80%, 95%, whatever number you look at is not 100%, and there are people that will present without fever, so we have to be very cautious in how we approach these patients. Additionally is cough. Cough represents probably somewhere in the order of 60 to 80% of the cases. That cough is typically early on non-productive. That means you don't produce any sputum. It's a dry cough. Additionally would be shortness of breath. Unfortunately, once we see shortness of breath, things have gotten advanced and there may be evidence of pneumonia. The interesting thing about this virus is that it has many other presentations, from relatively benign things such as the loss of smell and lack of taste, all the way to stroke-like symptoms, heart attack, heart failure, blood clots, etc. So this virus has presented a big challenge in terms of making the diagnosis.
Thank you, Bebo. The next question is for Dr. Mendoza. Dr. Mendoza, do younger kids get different symptoms? Do they experience, different symptoms just for being younger?
So we hear a lot about the coronavirus infection in adults, and it's true that elderly and older populations with comorbid conditions or pre-existing conditions tend to be more severely affected. But it's really not lost on us that kids can be infected and affected with the coronavirus. There is a bunch, some mounting evidence as to what the exact presenting symptoms can be. They are the most commonly, in the most recent report by the CDC that was put out on April 2nd. They put out these reports every 2 weeks. They try and track all the symptoms and symptomology of all the pediatric patients across the spectrum. 73% of them have fever or cough. That means that 27% have minor symptoms or no symptoms at all. Anything from sore throat, maybe a runny nose, maybe some diarrhea. So the spectrum is presenting in kids. Milder is the tendencies of presenting milder, but doesn't mean they're not getting infected. So most of the kids who are getting infected, the average age or the median age, the most commonly occurring age tends to be 11 years of age. And very, very young children are also getting infected. And there are even reports of neonates, newborns getting infected with their mothers or someone in their family being infected. So it's out there in pediatrics. Most of the people who get hospitalized, most of the kids who get hospitalized, if they get hospitalized, have underlying conditions like asthma, immune deficiencies, cardiac conditions. So it's important to realize that even though the news media is speaking a lot about the elderly population, older with comorbidities, it's very important to keep an eye out for kids because kids will get sick too. And especially if they have underlying conditions, they need to seek medical attention.
Thank you. The next question is to Dr. Bebo Collazo. Bebo, but what should you do if you think you have been exposed? What is it that you will feel before you should get tested?
Okay, so when someone feels that they may have been in contact with somebody who was COVID positive or someone that they think might have been COVID positive, or they start to develop symptoms, the first thing they should do is they should call their primary care physician. Now, they may not have a primary care physician. They may have another physician who has acted like their primary care physician, but they should try to get advice through their primary care physician. One of the things that's important to know is that people that don't have a primary care physician can use online features such as Care on Demand to get advice from qualified doctors. Baptist Health has a Care on Demand app that you can get on the App Store, and it's easy to register. Amwell, and there are others coming online as well. But you should get advice. That's the first thing you should do. It's important for us to be able to talk to patients like this in order to establish several important facts. One is the timeline of whether it's the timeline of the contact or the timeline of onset of symptoms. This is an important thing to discuss with the patient because someone knows when they may have been in contact with somebody, then it's important for that patient to know that every day, we know, for example, that the median or the average onset of symptoms is about day 5, okay? So if someone had a contact that was 6, 7, 8 days ago, we can start to assure that patient that even though they're not out of the woods, because the range may be as early as 2 days to 14 days, but that every day beyond day 5 is a good thing. It's no guarantee, and the further out you get, the better. We do have some outliers where symptom onset is 21 days, but that's not the norm. So it's important to establish the timeline because it tells us how we're going to follow up with that patient in terms of their outcome. The other thing is the symptom onset. If their symptoms start on a certain day, then we know that over the course of that first week, we have to monitor that patient for progression of symptoms. And more importantly, into that second week where we've seen a lot of people deteriorate, especially people who have comorbid conditions. So those are important features. Most importantly, initially, is to establish the severity of symptoms. And that's really a matter of just seeing how bad their cough is. Are they having shortness of breath? Have they had any other symptoms that suggest that their symptoms require more immediate attention? And then, just as important as Fernando mentioned, is the comorbidities, which essentially means, do they have other illnesses that we know can result in worse outcomes, such as people who have cardiovascular disease, hypertension, heart failure, diabetes, COPD, asthma, things like that. And so those are cases that we need to stratify. And when we have high-risk people, the bottom line is we're going to tell you, you need to go to the emergency room and get evaluated to make sure that you're not at risk for a poor outcome and probably be tested at that time. And then low-risk patients, we're going to tell them to stay home and quarantine and monitor their symptoms and follow up with them.
Well, thank you, Bill. And that leads into our next question. You just spoke about when we should go to the hospital when, when they start seeing some of those symptoms. And then for Dr. Mendoza, what can we expect if we have to go to the ER?
Right. So once you get to that point and you've made that assessment, either you've spoken to your primary care doctor or like Dr. Collazo mentioned, using Care on Demand. Now, the Care on Demand app, just to mention, is there's a free code for Baptist Care on Demand. Use Care 19, and anybody who puts that in will get a free visit, actually a few free visits. And we have a pediatric presence there too, so you can actually see pediatric ER doctors on that platform. Once the decision is made to go to the ER, here's what's been happening across really all of South Florida, and especially in the Baptist system, but across South Florida, a very similar approach. You'll be screened at the very front entrance before you even get into the ER. And by the way, I'll mention also that the ERs are there for a reason. They're there for sick patients. They're there. The doctors and nurses are there ready to take care of you. So there shouldn't be any hesitation. If you feel sick, if you think you meet one of these conditions, you talk to your primary care doctor, to Care on Demand. You get any advice to go to the ER, you're really not feeling well at all, like it's the worst time you've ever felt, that's time to go to the ER. Don't avoid it. You're not going to get coronavirus by going to the ER if you're really sick, okay? You want to take care of yourself. Don't avoid that. There's been an uptick in people getting really sick at home across the country and not seeking care, and that can be kind of the pendulum swinging the other way. Once you go to the ER, you're going to be screened at the front. There's going to be a triage nurse or tech. It's going to take your temperature, get your complaints. The minute you feel that, they feel that you're having a fever or cough or symptoms that are typical for coronavirus, most facilities, most ERs across the county, including the Baptist Health ones, have an area for you to go. They may look a little different in different ERs, whether it's a tent environment, which has air conditioning and providers that are already gowned up in their PPE, and they'll determine whether or not you meet the criteria for testing. If for some reason you're really in dire straits, having difficulty breathing, shortness of breath, whether you're pediatric or adult, many times they'll go right into the ER to a room and be evaluated to get x-rays and the right kind of blood work and assessment by the physician right away. If you're mildly symptomatic or maybe think you might have been exposed and you meet criteria, you'll probably go to a separate area where, like I said, is usually a tent scenario where you're separating out we call the coronavirus suspected versus a not. Remember, there's going to be people who have belly pain, pregnancy-related issues, other things, cuts and bruises, broken bones that don't belong in that area. They're going to be in a separate part of the ER. So I want those people they know that they're going to be safe and isolated. The next thing you'll expect is if you do meet criteria for testing, thankfully, in the past couple of weeks, testing capacity has been ramped up quite a bit throughout Dade County and throughout the Baptist Health System. So if you meet criteria, you'll get tested. You also may get a chest X-ray if you're having shortness of breath. And certainly if the physician feels like you need further workup, there'll be some blood work done, and you'll get oxygen tested to see what your oxygen level is like. It's all really going to be focusing on what your respiratory symptom is looking like. So be aware that the first thing you're going to run into when you get into an ER setting is they're going to screen you at the very front. The second thing that people have to realize is this is not a time for every family member to come to the ER. You come with your companion in the ER, whoever's going to bring you there, but there's a very strict, and this is for public health reasons, and Dr. Dowdy can certainly attest to this and expand on this. We're really limiting, and most hospitals have a no visitor policy with the exception of the ER. They don't want random people, lots of family members coming in because they want to prevent a spread or exposure in the community. But for sure, screening happens at the front end, and from there you get put to where they think is the best to be treated and tested. There's plenty of capacity in the emergency rooms across Baptist Health, and the doctors and nurses are specially trained, and daily, weekly updates on what to look for, what criteria are, and we're being fed all the CDC criteria and internally criteria to make the decision.
Thank you. That's very helpful. Dr. Capote, the next question goes for you. What can we expect if we get the coronavirus?
So really to piggyback off Dr. Bebo Collazo's statement, so he went into great detail about the symptoms. That's really the most important part of what you're expecting is a symptomatology of the COVID-19. Really, it's mild, moderate, severe is really what you're going to expect. In the mild cases, I think for the most part, the recovery time should be approximately 2 weeks. The symptoms are going to, include maybe some fever, headache, some of the loss of smell, taste, etc., maybe some diarrhea. Hopefully, at that point, the fatigue will start to kind of play off, and within 1 to 2 weeks. In addition, if you get to more moderate or severe, obviously what you're going to expect depends on where you are. If you're at home versus in the hospital. I think you're going to ask me later on in this conversation what to expect in the hospital, so I'll save that for later. But for the most part, what to expect is most of us will get better and will resolve within 2 weeks mild symptoms.
Okay, thanks. Now, I just want to remind the people that are watching in on the Columbus YouTube page, if you have any questions of your own, please hit the chat button on the bottom and you can ask questions and we'll get to your questions as soon as you ask. Next question, Dr. Mendoza. Once you go to the hospital, if you have to stay there for 2 or 3 days or so, or like a week or more, but what can we expect while we're in the hospital?
Well, as far as being admitted to the hospital, I mean, certainly there's a couple different areas where patients are being admitted to, and depending really how sick you are. Like Dr. Capote said, most of the people who are getting tested, it's across the county, reflects a lot of what's happening across the country. About 10% of people who get tested are positive. Okay, that's only 10%. So 10 out of 100 people may end up positive. Out of those 10, not many are going to get hospitalized. They're going to go home and have symptoms. If you get hospitalized, the first thing you're going to be stratified or kind of risk stratified or assessed is how bad is your respiratory symptoms. If you're having a really hard time breathing, you may need supplemental oxygen, you may go to an area that needs support with respiratory support and oxygen like that. And the doctors will keep track, the ICU doctors, like Dr. Capote's service, will keep track of what your oxygen requirements are and can basically provide assistance for oxygen supplementation. In rare cases, and the more severe ones you're hearing about, there are some times where you need to have a breathing tube inserted to help support the oxygenation until the lung damage subsides and the breathing tube can be removed. But it's important to note that most people that get tested in Dade County right now, only about 10% are actually coming back positive. But as far as the admission course and what happens in the hospital, I think that's a great question for Dr. Capote to elaborate on, and when it comes to the adult world.
Dr. Capote, if you want to chime in.
Yes, thank you. So obviously there's different levels and I'm in the ICU. So, and Dr. Dowdy will probably talk a little bit about how things have changed since the beginning of the crisis. What we have noted was when this first came to, I guess, Washington and Seattle, the first reports were intubate everybody. If you have any signs of hypoxia or low oxygen, and your x-ray looks like there's a lot of inflammation, a lot of pneumonia, we're putting you on a ventilator. What we soon found out is the mortality was going up significant on patients with ventilators. It started off worldwide, I think in Wuhan, if you believe the numbers, and to neighboring countries was about 50% mortality on a ventilator. Seattle, the first 23 patients, I believe, 13 or 15 of them died on a ventilator. So as the disease started to spread across the country, and ventilators became kind of short in New York in particularly, we were actually becoming more tolerable of our threshold of placing a patient on a ventilator. We were using different types of modalities to oxygenate them. One of them is called high flow. High flow is a nasal cannula, like you've seen in maybe Publix, so people dragging it around, but it gives it gives oxygen at a much higher rate, much higher flow, and it's pure. It's blended to 100%. Originally, when the CDC gave out the first guidelines on how to manage COVID-19 patients, they said we should not use these devices because they were afraid that a lot of the virus was going to be aerosolized. One of these devices is called Vapotherm. It actually vaporizes it where there's very little aerosolization of the virus. So we've been using this pretty much rampant now in most of the hospitals across the country and in South Florida. In particular, Jackson Health System has purchased many of these. And I would probably say my first 2 weeks experience with COVID-19, we were pretty readily placing patients on a ventilator. Probably about 17 to 19 patients were placed on a ventilator in my service, and our mortality was around 70%. So the following 2 to 3 weeks, similar patients, similar comorbidities, we managed them with high flow or the Vapotherm. About 10 to 12 days later, I had about 9 patients, none of them were intubated, and 4 of them were discharged home. That was in conjunction with some of the medications that are used for COVID-19, I'm sure Dr. Dowdy will get into. That's really the main thing. When it does come to ventilator usage, and if the patient does require ventilator usage, some of the things that we are employing are lung protective strategies where we try to limit the amount of pressure we give on a ventilator. try to limit the amount of inflammation. It's all about inflammation. We do use proning, which is we flip the patient over on his belly to kind of help recruit the posterior part of the lungs that have a lot of dependency on them and are collapsed. We also use paralytics. We use different type of devices, a vasodilator called Velitri or proportional. That does, it vasodilates the arteries of the lung and helps perfuse the lungs a little bit better, helps oxygenate. One of the more exciting things that we're doing, and we just got a approval from the FDA and IRB at Jackson Health at University of Miami, is we're using nitric oxide through high flow, which means that we're giving the device of nitric oxide of vasodilator through a nasal cannula, and we're improving oxygenation in that standpoint. Everything that we have learned in the last 3 to 4 weeks, we'll probably re-emphasize to try to be a little bit more tolerable of not putting patients on a ventilator because the mortality is so high.
Thank you. And that leads up to actually to Dr. Gotti, with our next question is, what treatments work to decrease the severity of COVID-19 disease?
That is a very loaded question. Let me go back to the beginning of March when I saw the first patient that I took care of. All the recommendations that were made at that time by the people who had experience both in China and the cases in Washington have almost all been put aside. So let me start in the beginning. A month and a half ago, 6 weeks ago, we were recommending using a certain medication that was used in treatment of patients who had HIV in conjunction with an antibiotic called azithromycin, which everybody knows as a Z-Pak, and antimalarial drugs called hydroxychloroquine or chloroquine. And in the beginning, some of the literature suggested that these medications, either by themselves or in different combinations, may be helpful in treating patients who had COVID-19. Over the last month, that has almost completely gone in a 180-degree direction. So let me just start out by saying that we have no proven medical treatment specific to the virus for people who have COVID-19 infection. So there is no medication that we can say for sure is worth giving because it definitely works. We're still working on that. We're hoping that with clinical trials that are being done in multiple places, including in the United States, that we'll have some better answers to that later on, maybe probably closer to the end of the year. So right now, our strategies are primarily to support people. The intensivists are doing a great job, and Dr. Capote already mentioned that the whole idea of how to give people additional oxygen and help them breathe without causing additional lung damage is one thing. We are still using some of the medications that have been mentioned in specific circumstances, and the hope is that by studying which patients do well with certain interventions, we can actually come up with some more sure data on how to treat people. So I would say the take-home message here is we don't have any specific treatment for the virus itself. We may give people antibiotics, we may give them antivirals, we may give them certain medications that have been used in other areas of medicine, specifically areas where the immune system is out of whack. So for instance, some of the medications that we are using in people who have an overwhelming inflammation, a response that is so overwhelming that it actually causes more damage than it helps as part of the body's own defenses. We're using those medicines to try to block that defense or tamp down that defense to give the person a chance to heal without having that additional damage. So we have no medicines, we're working on it. There are a couple of other trials that are going to be taking place as time goes by. I think one of the things that we're hoping that people who have proven to have COVID-19 infection and recover consider donating blood. There are clinical trials now, and South Florida hospitals, both the systems that I work in, are looking towards being part of those studies where we give plasma from people who have recovered to people who are very ill. And hopefully that will give us some kind of intervention other than just manipulating the immune system and give us another option that we can use for people who are critically ill. But I would strongly caution people not to get bootleg hydroxychloroquine. We've seen a couple cases, at least one situation in Arizona, very sad, that a couple saw that as an ingredient in a fish tank cleaner and decided to take it in order to prevent getting COVID-19. And the husband died and the wife ended up in the ICU. So be in touch with your doctor, take the advice of your doctor. Don't get any of these medications under the table from friends or family members, and trust that, you know, we will do everything to help people get better and recover without actually causing any harm.
Thank you. And to piggyback off of that question, Dr. Mendoza, next one is for you. Are there any side effects from the home remedies or taking any medication that's unapproved? Dr. Mendoza, you're muted.
Just to back up what Dr. Dowdy said, the local poison control center published their most recent findings today, and in the last month, ingestion poisonings for bleach have tripled. People are taking bleach or bleach derivatives, whether dry or in liquid, and trying to clean their mouths, trying to ingest them to prevent the infection. That doesn't work. Not only does it work, it's very, very dangerous. Chemical ingestions or household disinfectants and products do not work to prevent this virus. And so they saw a threefold increase in that from beginning of January to mid-March. Those have tapered off a little bit, but still significant enough for them to publish it. For sure, the chloroquines that are out there in the fish in the aquarium setting, like Dr. Dowdy mentioned, those are not the same thing as hydroxychloroquine, and those can definitely be toxic and deadly. So what doesn't work? Drinking lots of alcohol to sanitize from the inside is something that poison controls are getting a lot of. So don't drink a lot of bourbon or rum or vodka. It's not going to help you clear the virus. No fish tank treatments. Don't spray any toxic chemicals inside your mask or on your groceries. Be really careful about what you're putting on your groceries, on your vegetables. Certainly there's a tendency to want to sanitize everything coming into your house. Don't take massive doses of zinc and vitamin C. That's not recommended. And definitely do not rinse your mouth with bleach. That has been happening. Poison control is getting those calls. If for some reason a family member, you find out someone's done that, you can go ahead and call poison control, which is 1-800-222-1222. That's a national number. You can Google it. So call your poison control center in case any of that happens.
Thanks. That's good to know. Next question for Dr. Dowdy again. Can a preventive medication be identified to be given to people that, like we know that came in contact with someone that's tested positive for the coronavirus, but like it's done with people with the influenza, with the Tamiflu, like in nursing homes? Is there anything that can be given to those people?
Well, the answer to that is no. Realize that we are building, what's happening now with COVID-19 is tantamount to trying to build a house that's on fire, right? So we don't have a lot of information on any treatments that are good for people who are sick. And we certainly have even less information on what to do with people who are exposed, who are not sick. So I would say this, we are hoping, and there are clinical trials now that are starting to determine whether or not any of the things that are being used for treatment trials would be helpful in preventing people from becoming ill. But the answer generally is no. We don't have a Tamiflu equivalent for COVID-19. We don't have any specific treatment for COVID-19. The best way to protect yourself is to do all the things that we've been told to do. Stay home, try not to touch your face if your hands aren't clean, hand sanitizer, hand washing, 20 minutes to happy birthdays in your head. Stay away from family members who may be sick if you are not a close member in the home, but there are no medicines that will prevent it. And I would echo what Dr. Mendoza said. Please stay away from the internet and the recommendations for taking massive doses of everything, zinc, vitamin C, I've seen other people recommending ginger and turmeric and all kinds of other herbal remedies. Generally speaking, I would say no. The answer is stay away from those things. There may be in the future that we have some information on that, but for right now, no.
All right, thank you. And we have our first question from one of our audience. And just to remind everybody, if you have a question, if you tap on the chat button on the bottom, and you can type in your question. This question comes from one of our audience members, and it goes to Dr. Jerry Capote. I'm guessing, Jerry, it's one of your classmates. It says, Dr. Jerry Capote, if someone contracts the virus after recovering, is there any permanent damage to your lungs? And they also want to know, how do you keep your mustache but looking so good? Dr. Capote?
That was quick hazing. It only took about 30 minutes. So what we know about, so what they say when you get any type of virus or any type of lung damage, they call it ARDS. Okay, this is what's causing it. It's an inflammatory reaction in the lung. Generally, let's just talk about, because this is such a new thing and we haven't seen that many patients recover yet. So I would probably just say in the terms of ARDS or inflammation because of a virus or pneumonia, less than 1%, probably less than 2% of the patients will have permanent lung damage. What we have seen in COVID-19 cases that are requiring ventilators is the amount of damage to the lung is pretty substantial. Most of the patients that I've seen that have left the hospital have not left with no more x-rays. Truth be told, we won't know what their lung damages are going to look like maybe till about a year down the road. But generally speaking, it should be less than 2% will have permanent lung damage. And if you have an underlying condition like COPD or emphysema, that's obviously going to go up a little bit higher. Generally, you probably won't get back to your baseline before you contracted the disease or the infection, but you should have some recuperation. And my mustache. So this has been a pretty troubling time for us in the ICU. We were at Jackson Health, and specifically in the North area. We actually had the first couple cases of COVID-19 in all Jackson Health, and we had a couple families come in, and unfortunately we had a pretty big hit of mortalities in families, like Dr. Dowdy said. So me and a couple of the ER guys, we were forced to shave our beards to protect ourselves from the N95 so they can form a seal. So we decided to have a COVID stash, just to to kind of keep the attitude a little bit light in a time of darkness. So thank you.
Thank you, Dr. Capote. Next question is for Dr. Bebo Collazo. Bebo, how common is the spread from contaminated surfaces?
Well, contaminated surfaces has long been known to be a source of spread for many viruses. As we classically learned in medical school, the term fomites. This is something that is very important in the spread of this particular virus when there are known positives in a household. This goes back to the issue of quarantining a person who is otherwise healthy. The issue of quarantining is not only staying home, but it's also distancing with other household members. It's also infection control in the house, which is primarily that, which is those people in the household, if they're with a COVID positive patient, they need to, if they're going to be in the same room, they should preferably wear masks, and they should clean up after all commonly touched surfaces or frequently touched surfaces continuously. There's probably some rate of cleaning that is recommended, but I would say continuously. It's very, very important. And I just want to go back to the issue of the supplementals that Dr. Dowdy mentioned. It's important for people that are on cardiac meds and other type of chronic meds that they need to know there's interactions with some of these over-the-counter supplemental medications with their cardiac meds. Some of those interactions can be detrimental. So always ask your doctor about those kinds of things, whether related to taking it to prevent COVID or whether related to any other desire related to supplemental meds. It should be something that you discuss with your physician.
Okay, thank you, Bill. And we have another question from one of our audience. Tati Milan asks, for any of the doctors, any news on the saliva/oral testing for the coronavirus?
Lorraine.
Let me say, okay, so the issue of testing, that's been a very thorny issue throughout this whole process. There are many, many tests that are likely to come online within the next weeks to months. Some of these tests are being put out under what's called an emergency use authorization by the FDA. What does that mean? Well, generally speaking, if someone is going to produce a test that will be sent out, they have to spend months, years developing the test, validating the test, meaning that they know they can tell us how specific the test is, meaning that if someone has the disease, the test will be positive, how sensitive it is, it will pick up a certain amount of cases. So these tests that are coming out right now, many of them have not gone through that degree of rigorous development. So there are finger stick tests coming along, there are saliva tests coming along, but at this point, it's very difficult to say how useful it would be for making the diagnosis in an ill person. What they will be helpful for will be to determine how many people may have had the disease and had no symptoms or very, very mild symptoms, and give us some, from a public health standpoint, people already have been exposed. These tests, again, are coming out slowly. The most recent test to be approved as a rapid test is just in production. It's being made by a company called Abbott, and they're planning to make about 50,000 tests a day and ship about 50,000 tests per week. So that started Friday. So the saliva tests, we'll see how helpful they are, but there are about 12 different tests of varying kinds that will be coming out over time. So for right now, I think that those tests will be more helpful in determining people who have recovered but not necessarily for people who are ill.
Dr. Mendoza, do you wanted to add something to it?
No, I'm good. I mean, I agree. I mean, I think that she covered all the bases. And when it comes to antibody testing, certainly, I know the Abbott tests are online within Baptist Health, but antibody testing is something we're all eager. I would warn against the consumer or off the street antibody testing that's being promoted out there. We don't know where those membranes are coming from in terms of the accuracy. The FDA has allowed these to come into the market, but there's no proof of how accurate they are, whether sensitivity or specificity from a scientific perspective. So there's a lot of unsavory characters out there that'll charge, any amount of money to someone to get an antibody test. We just simply don't know, how accurate those tests are. I would follow the lead of your local health systems. Baptist and Jackson are going to really put forward the best testing that they can. So when you see those come online in those healthcare systems, you'll know they have some pretty good data. But right now, there's some tests out there that are being advertised. You might have local labs or someone trying to put it out, or people who advertise to have an antibody test for you that they have a whole shipment for you that they can access. I'd be really wary of that.
I'd like to make a comment on the testing as well. One of the reasons why we have kind of stratified the levels of testing is because we don't have enough tests. This is ramping up, as Fernando said, but right now, if you look at in the United States, I believe we've tested about 1% of the population, of the entire population, 1%. And so we have to stratify who should be tested. And so there's a lot of people that have no symptoms, have had no particular known contacts, and they want to be tested, and we have to tell them you can't be tested. You are the lowest priority. So we have to focus on the people who are hospitalized, who are severely ill, to confirm their diagnosis. We have to focus on the healthcare workers who become symptomatic in the process of taking care of these patients. And then we have nursing home patients if they become ill. Those people need to be tested. We have the elderly who are at risk. We have people with heart failure and emphysema. All of those people, first responders, those are the people who are at the front of the line, unfortunately. If in a perfect world, we'd be able to test everybody, but that's not the case. So we have to use the strategy of using best judgment, identifying people who may be at risk, who have low degree of symptoms, and quarantine those patients without testing, and monitor them, because they may develop severity of symptoms over time, beyond the first week that then will require them to be testing. So that's one of the reasons that we're stratifying the use of testing. And keep in mind also that the testing that's used, this PCR testing that we're using, if you look at all the reports that have come out talking about the sensitivity of this test, we're talking about somewhere in the order of about 70%, maybe 60 to 70%. What that means is that you want a test to be 99% sensitive, because that tells you that if the test is negative, you do not have the disease, okay? But if the test is only 70% sensitive, that means 3 times out of 10, you're gonna get a false negative result. So we're better off in low acuity patients going with identifying risk, identifying the symptoms, quarantining those patients, infection control, and monitoring them rather than testing them.
Thank you. That's very helpful. I know there's a lot of questions around nationwide just for the testing, so you know that helped out a lot. Another question from one of the audience, from Michael Carrillo, asked to any of the doctors, I've heard comments that for those who have the COVID-19 symptoms, they should avoid ibuprofen or Advil and take only Tylenol. Is there any truth to the ibuprofen worsening the COVID-19 patient?
Well, let me just jump in here and say that the idea of ibuprofen and Aleve and things in that family, non-steroidal anti-inflammatories. One of the things that we've seen with COVID-19 is that some people develop renal failure, kidney disease, and certainly taking high doses of ibuprofen and Aleve can contribute to kidney damage. So that's probably one of that, but one of the things that led to that recommendation. So Tylenol and not ibuprofen in this setting. And for Dr. Capote, I don't know if you've seen any people who have come in with renal failure, but we've certainly seen quite a few of these people with COVID-19 severe enough to be in the hospital, and particularly those who have ended up on ventilators with kidney failure at some point during the course of disease.
Yes, actually, we did a review of about 24 patients today who did die from COVID-19. We went through all their comorbidities or their pre-existing conditions, and one of them was there was 3 things that stood out the most, and this is kind of has maintained the trend, is diabetes, chronic kidney disease or underlying kidney stuff, you know, the kidney disease or some type of kidney failure, and hypertension. And they all kind of play really with each other. You have longstanding hypertension, you may get some longstanding chronic kidney disease, and you usually may have underlying diabetes. So I agree, it's been anecdotal, but I've told my patients that in the ICU, we don't use ibuprofen. There's other things we can administer. So even to my family member, I'd say just avoid it.
There's another reason also, and I might add, obviously there's also some theoretical considerations regarding the anti-inflammatory effect of non-steroidal anti-inflammatories and whether it blocks actually the production of antibodies and things like that. But just as you have that argument, there are other arguments that say the opposite. So there's no clear evidence except that we know that the use of anti-inflammatories, someone who's already ill, can cause a lot of secondary problems with people with kidney problems, et cetera. But I will say this, and this is something that Dr. Dowdy and I have talked about as well, is that fever is actually, there's a reason people get fever. And the reason you get fever is an immune response to try to kill the invader. So when someone, there's studies that show when someone gets fever, as that fever goes up, the viral load in the body goes down, okay? So if the fever is brought down artificially with medication, they've also shown that the viral replication increases. So the point is that you should not take ibuprofen or Tylenol or anything that's an anti-fever medication at the drop of a hat. And if you are relatively young, you should and able to tolerate some fever. Fever is actually a beneficial mechanism. Now, there are people that cannot tolerate certain fevers, people with underlying comorbidities, but for some people, fever should be tolerated and you shouldn't go right to Tylenol to try to lower your fever.
So Bebo, just to piggyback off of that, so if like for younger kids, and maybe Dr. Mendoza, you want to chime in on this, for those who have younger kids, you know, kids 8, 9 years old, when they have a fever, should we try to avoid, you know, unless it gets, you know, like a really high fever, should we not give them something for the fever until it gets really bad, or what's the recommendation?
I have this discussion with parents every single day in the ER. I mean, fever, like Dr. Collazo mentioned, is a normal body's normal response to infection. So what I tell parents is that if the child looks well and they're happy and you're not being bothered by a low grade fever of 101 or 100 point something, you don't need it. Certainly, when you get a fever and the child's uncomfortable, or a lot of times kids will get down, less active, you give them a little Tylenol, and we actually only approved or really allow ibuprofen over 6 months of age. And even then, we prefer Tylenol. It's less toxic effects, of course, that we alluded to before. We're finding out a little more and more that ibuprofen can affect the kidneys a little more significantly. And then they bounce back after you give them Tylenol or Motrin or ibuprofen. If it's for comfort, that's fine. Don't be afraid of fever. There's no magic number that says that fever is going to cause brain damage or going to be the one that's going to really, cause a febrile seizure. Kids who get febrile seizures, which has really nothing to do with COVID, as far as we know right now, they get febrile seizures. It's about really a certain percentage of patients, especially boys will get febrile seizures when they're young, or can get febrile seizures. It's going to happen when they get 101 or 103. Another point I wanted to bring up is we're thinking the pediatric community is a little concerned about the avoidance of seeking care with their primary care doctor or pediatrician during this time, because don't be afraid to go to your pediatrician for your normal routine care. Almost all pediatric practices, they're all open as far as I know, all the local ones. And they're reserving the morning times. Typically, you can call it ahead of time, either morning or afternoon, for the well child visits. Why is that important? You don't want to skip the normal vaccination schedule that your child is supposed to be on in lieu of going because of the COVID crisis, or pandemic. We're actually concerned, the pediatric community is concerned, we're going to see a rise in vaccine-related diseases, things like chickenpox, measles, pertussis, Haemophilus, which we hadn't seen since the early 90s, or late, mid 90s, which are devastating diseases. We don't want to have, COVID, everyone being afraid to go to the doctor because of COVID, being, in an office, and have the unintended effect that now you have these delayed vaccines and an upwelling of vaccine preventable diseases. So do not avoid your normal vaccination schedules. Super important to get that done with your pediatrician. So fever itself, not dangerous. Kids actually tolerate fever. I've seen kids running around the ER all the time with 103s, 104s that would knock one of us kind of down in bed for a while, but they're running around like nothing, because then that's the way our bodies are built. Don't have to be afraid of fever, but you can keep track of it. It is a sign of an infection. Most fevers in kids are viral. Most viruses that kids are going to get, even right now, are not going to be COVID. They're going to be parainfluenza, maybe even influenza, rhinovirus, enterovirus, metapneumovirus, all these other viruses that we see that Dr. Dowdy knows about, we see in occurring in the community. That's most of the reason why you're going to get a fever. Very rarely is it going to be due to coronavirus these days, because, like I said, only a small percentage, about 2% of the people who actually have coronavirus are actually kids.
Thank you. Next question for Dr. Capote. What can a patient expect if they go to the ICU? And does everybody that go to the ICU, do they have to be intubated?
So we did speak about this a little bit. So pretty much like Dr. Dowdy said, everything we talked about or we learned about this disease 6 weeks ago, 8 weeks ago, we've kind of changed our management about it. So hopefully you don't need to get intubated, and we really become tolerant of having lower oxygenation as long as the patient has a good mental status, is speaking well, is protecting their airway or managing their saliva and their sputum. We're trying to keep them off the ventilator as much as possible. In the ICU, obviously things are very different. We have more access to different type of medications, drips to put you in different type of states, where we can do different things, different modalities with the ventilator. But in terms of being on the ventilator, hopefully in all of Dade County, there's been a change of trying to avoid ventilation or mechanical ventilation as much as possible.
We have another question from the audience. We have Santiago Eljak from class of 91. He wants to Dr. Gotti. How does the plasma of a previously affected person help with someone that has gotten the coronavirus?
Excellent question. And the answer is right now, we don't know. But one of the time-tested ways of treating people who have certain kinds of infectious diseases or illnesses has been to use the blood from somebody who has recovered. And that way we can use their immune response, their antibodies to help the person who is currently ill. So at this point, we hope that for COVID-19, the plasma from a recovered person will help transmit their immunity into a person who's very ill. Do we know that this is going to work? We don't know. But what we do need to be able to do is to collect blood from people who have recovered and trial it to see if it will actually help people who are critically ill. So again, this is all changing at warp speed practically, but we're hoping that this as a time-tested way of helping people who have different kinds of infections will also work for people who have COVID-19. So again, if anyone out there who has had COVID-19, has recovered, I'll plug One Blood, local blood bank is looking for people in that category. You cannot be ill, you have to be tested, and that's part of the protocol to make sure that you don't have active disease, but they will be asking people to donate blood, and that blood will be used to help maybe treat somebody else.
I'm wondering if Jerry has had any, have they used any convalescent plasma in the ICU setting?
We have not at Jackson Health yet. I'm not sure if Jackson South is doing it, but at Jackson Memorial and Jackson North, we have not. We have used a lot of tocilizumab. We haven't got on our hands on remdesivir, one of the other medications out there, and obviously plaquenil azithromycin. We have not used any plasma just yet. I know that some facilities are starting to use IVIG. I'm not sure if it's being used down south in Jackson South or Baptist, but we have not used IVIG either, or immunoglobulins.
So as an update, there's an ongoing study with Dr. Dowdy mentioned in partnership with One Blood at Baptist Health, and people who have convalesced, who have recovered, right? By definition, convalescence means you've recovered. Can call a number 786-533-4444, and they can they're working with Baptist Health System in South Florida, up in Boca as well. They've done a few patients, a handful, I think just under 10 between doctors, Baptist, South Miami Hospital. I think one or two at Boca, Baptist Boca. So it's an ongoing therapy. They're enrolling patients. There's a lot of donors who are lining up, thank goodness. And you have to be blood type to be matched to see if you can donate. But hopefully in the next few months, we'll be able to see more publications about that nationwide and locally, see if that helps.
If you have had COVID-19, you had a mild course, you recovered. If you have documentation of your positive test, you need documentation of a subsequent negative test for One Blood, and then you're good to go.
Right.
I think there's some promising early data with this.
Okay. Next question, just to piggyback off of this is for Jerry. This question comes from Janet Reborero. Janet, sorry if I mispronounced your last name. Dr. Capote, are you using tocilizumab? I must spell it out for you, Jerry. TOC.
Tocilizumab.
That sounds about right.
Yeah, that was it.
At JMH, and you're seeing positive outcomes. Thank you, Dr. Gotti.
Yeah, so we're just shortening down, call it TOSI. So, my experience so far in the pulmonary floors and in the ICU, I actually think this is probably the only medication that I've seen a positive response from. I don't know what Dr. Dowdy or Dr. Bebo's responses have been or what they've noticed. Generally, what we're doing is we're giving it early in the course of the disease. Most patients are already on plaquenil or azithromycin. If they meet criteria for TOSI, we're giving it an infusion. It's mainly for the cytokine storm, which is a big inflammatory response. I've noticed a slight improvement in X-ray 24 to 48 hours after the infusion. And I've also noticed a little bit of an improvement in oxygenation. Most of those patients that have received it are moderate to severe in disease. So they're pretty far gone. Some of them have received it on a ventilator. Now, on a ventilator, I have not seen any improvement where a patient has gotten off the ventilator who has received tocilizumab except for one patient. And that's probably out of maybe over 30. But off the ventilator on either high flow or another oxygen modality, I think I've seen a fairly good response. I think definitely better than Plaquenil and azithromycin. So we're using it pretty readily at Jackson. You have to meet certain criteria, but we definitely have a good stock amount and we're using it plenty.
Okay. Next question is from one of our teachers, Ms. Christina Insua. There's a fear of people going, I think we talked about this, and this question will go for you, Dr. Mendoza. There's a fear of people going to the ER for non-COVID related issues. Is it also safe? Is it safe to go to ER right now? If you have a real emergency, would you have to be quarantined for 2 weeks after?
It's absolutely safe to go. And please do not delay serious medical conditions and stay at home when you're really ill. You do not have to be quarantined. Not everybody who walks in through the door of a hospital has to be quarantined. Okay, the first thing that will happen is you'll be screened at the front. If you're having a non-COVID related complaint, let's say abdominal pain, broken toe, a foot or something like that, you'll have a temperature, they'll put a mask on you. And that mask, and the mask that we're all wearing, by the way, in Baptist Health, everybody in the hospital, everybody everywhere needs to put a mask on. That's to prevent everyone from infecting each other. Okay, it's not so much for the inspiration, it's for the expiration. But you'll get put into an area that's what we call the clean area or non-COVID area, and be treated for your appropriate condition. Do not avoid, if you have chest pain, if you're a diabetic having DKA symptoms, if you're an asthmatic as a kid especially, or even an adult, you're having asthmatic symptoms, respiratory symptoms, go to the ER that you normally go to. You do not want to avoid and handle this stuff at home, okay? This is, you're not gonna have to be quarantined when you come out of the ER. Even though someone in your family may think, well, you've been to the ER, now you're dirty, well, wash your hands a lot. If you want to bring yourself, your Purell with you, and be careful what you're touching. Get home, take a shower after you go for the ER, wash off. You wipe everything down if you want, that's fine, but you don't have to be quarantined for 2 weeks after you come home from the ER if you've been treated.
I'd like to echo on that as well, Flash, that one of the things, there's actually models coming out now talking about the potential fourth wave. And the fourth wave is the consequences of people who have chronic disease that require management, that are not going to see the doctor. They're offered telemedicine. They don't want to do the telemedicine. And then if they have acute illnesses, they're not going to the ER. And that's the fourth wave of this, is that we're going to see the consequences of poor care because of gaps in care with these people not seeking acute care in the emergency room and not following up with their doctors because they don't want to leave their homes, which is great not to leave your home. But if you have an illness or if you have a condition and your doctor says, come and see me, that's good advice.
So just one more comment on that. The dirty little secret, it's not dirty little secret, the ERs are empty. There's the people who are in the ERs right now are the really sick people, and people are avoiding it. There's plenty of capacity. We have plenty of areas at all across, Baptist Children's ER, the adult ER, South Miami. There's plenty of space. There aren't people showing up to the ER. Where all the ER doctors are looking at ourselves saying, what's happening here? What happened to, we know the broken bones and the lacerations in kids are because they're not in school. But the chest pains, there's been an 800% increase in New York City of at-home cardiac arrest and deaths because people are avoiding going to the ER and they're dying at home. If you're sick, if you have a condition that's chronic, need to be managed, if you're having an exacerbation of asthma or a cellulitis or an infection, go get the appropriate care. You can start off with care on demand. That's fine. And the Care 19 is a free code to get you in, or call your pediatrician or your primary care doctor. But do not delay going to the ER or to an urgent care because you're afraid of getting of contracting COVID.
Thank you. Next question is for any of you. I'm a type 1 diabetic in my 40s. I'm in good shape. I ride a lot of bicycles. But what should I expect if I get the coronavirus? Does being in good shape help? Fernando?
Well, there's no question that there's no question that being in good shape is going to help. There's no doubt about that. The more cardiac reserve you have, the more pulmonary reserve, the better you're going to do if you get ill. However, if you are diabetic, the experience so far has been that you have a higher chance, not of getting the virus, of getting COVID-19, but rather of having complications from COVID-19. And so someone who's diabetic is someone who should pull the trigger on getting an evaluation and advice from their doctor immediately upon having anything that may remotely sound or feel like it's COVID-19.
You know, and also comment on the exercise portion. Whether you're cycling, we're seeing a lot of people. I see more people out in the neighborhoods now running and cycling than ever before. And there's, you know, we talk about social distancing, about staying far apart. And, you know, I don't know if Dr. Dowdy has any comments about the transmission, but there's certainly something to be said about the respiratory droplets when you're exhaling and running and, you know, doing that. You want to keep your safe distance from whoever you're cycling with and you're running behind, okay? I probably wouldn't recommend cycling one of those big pelotons with a bunch of people, you know, breathing all over you. Probably not a good idea. Same way you wouldn't want to breathe all over somebody. So, you know, be careful with the exercise regimen. It's great to do that, but just, you know, you want to stay, you know, probably even more. And I can't recall, but it was a Wall Street Journal, New York Times, talked about the transmission risk and people exercising together and running behind somebody, you know, has to be further apart than
Yeah.
you know, alone. So keep that in mind.
That is true. Exaggerated exhalation. Those are things that are going to aerosolize someone who may be inadvertently asymptomatic and can shed virus if they're asymptomatic, can be out there exercising and you're running 3 feet, 4 feet behind them right in their draft, and that's not a good idea.
Right. Next question
Just
for
to remind everyone,
Capote?
that, I'm sorry,
Right.
just to remind everyone that in Miami-Dade County, you know, we are supposed to be wearing masks in public areas. So if you're going to be exercising, that's not a bad idea.
Including exercise.
Okay, next question, Dr. Capote. How effective is increasing the ventilation and reducing the risk?
You know, I guess you're talking about air quality or air circulation, probably pretty good for lung diseases like asthma and maybe some reactive airway disease. I don't think it's really beneficial in COVID-19. I would probably say, kind of like what Dr. Bebo said and Dr. Fernando, just kind of avoid social distancing and quarantine is probably your best way of reducing your chances of acquiring the disease.
Right. Another question from the audience is from our own Dr. Villa. Why are the numbers of the COVID-19 cases rising rapidly across the country, even as our cities have become eerily quiet for almost a month if the incubation period is 14 days? Any of you know what I think?
Well, let me say this, that, you know, the disease that we see is reflective of exposure that's prior to the person or the people becoming ill. So if you imagine that one person comes in contact with 4 or 5 other people, 1 or 2 of those people become infected, there's a lag phase. So we're seeing now, it's kind of like a wave building. We're seeing the results of exposures that took place a week, 2 weeks, 3 weeks, maybe before. And so that's why we all need to stay away from each other to give a chance for that exposure to dissipate so that we're not continually passing the disease on to other people. I don't know if anybody else had any.
Yeah, this is definitely not the time to let up with social with distancing. It's important to note that Florida is lagging behind New York and other states, and our peak mortality, as we were mentioning before, is estimated, it's May 3rd or May 6th, something like that. And so if we are currently on a curve going up towards May 6th, then the middle and late part of May, we're back to where we are now. It's not the time to let up. We have to continue to use caution, because that's what's going to flatten this curve and reduce the rate of transmission, the transmissibility from one person to the next. That's our best defense.
I concur. I agree with my colleagues. Also, you know, your asymptomatic kids getting together and throwing a lacrosse ball around or biking together or having a play date because, you know, the adults are on one side of the street and the kids are playing in the middle. That's not social distancing.
Let me give an example, Flash, of what happened in Washington State. And I mentioned this to Dr. Dowdy. There was a choir that was practicing before they knew what was going on here. And there were 60 people in the choir. And then when you're singing, you're close to each other. And it's basically exaggerated speaking when you're singing, and you're aerosolizing a lot of your breath. And 40 of the 60 choir members came down with COVID. 40 of the 60.
Sad. Wow. Next question is actually from one of our coaches, from Dr. Dunn, from Coach Dave Dunn. Why are relatively healthy young people passing away from the coronavirus and other people with comorbidities surviving? Any of you don't want to take that one?
Well, I think probably Jerry can speak to that, but I will say that that's an anecdotal experience. The truth of the matter is that the older people and people with comorbidities have a far higher mortality than younger people. And certainly even in the pediatric experience, under 20 years of age, the mortality is very, very low. So I don't know if Jerry could speak further to that.
Yeah, I agree. You know, I had a 42-year-old male come into the ICU about a month ago. His father and mother actually admitted to the ICU at the same time. It was told to me that the patients had no comorbidities. So, you know, we did some investigation. They had announced it as no comorbidities, but as we kind of just did the blood work, his hemoglobin A1C was checked for diabetes, like 11. And he had some proteinuria already in the urine. So he was morbidly obese. He had diabetes, but he had nothing in the chart that said I didn't take any medications. I was sort of an unhealthy guy. So he went down as having no comorbidities, but he was most likely a type 2 diabetic, morbid obesity, probably some underlying hypertension. And he obviously had a negative outcome. So it's really anecdotal. I haven't seen really anybody come in and have a negative outcome who really is a healthy person. Maybe some of my colleagues at some of the other hospitals have, I have not personally.
Okay.
I don't know. Maybe Dr. Dowdy has some experience with that.
I would say that there will be young people who have bad outcomes, and we don't know why exactly that may be the case in people who are totally healthy. I think one of the things that we don't know too much about this disease is the anecdotes that we have, the stories that we have from physicians in China and in other places of young people dying suddenly when they seem to be on the road to recovery. We don't know what the effect is on the actual heart muscle. And maybe in certain of these young people who die, it has more to do with the effect on the heart muscle and maybe causing the conduction system, the electrical system of the heart to malfunction in a catastrophic way. So young people are not dying disproportionately compared to older people, but some of the young people who die who are seemingly healthy, maybe that this is an effect of the virus on the actual heart, the conduction system of the heart and the heart muscle.
And that is a great point, Dr. Dowdy. That's been my experience as well, is most of my negative outcomes have actually been from a cardiac arrest, not pulmonary in origin. Usually it's either a lethal arrhythmia like ventricular fibrillation or just asystole. So I agree. I think this virus is really attacking the cardiac muscle mainly, even though the echoes or ultrasounds of the heart are normal at the beginning. Generally, late stages in the disease, there is some damage to the muscle where there is a frank reduction of output, I would say.
And the paradox is also that, young people, they have brisk and very strong immune systems, and it is partly to blame our immune system for the inflammatory response that's causing, what we call systemic inflammatory response syndrome. This is the kind of thing that we're seeing where the inflammation that's systemic is causing decompensation of multiple organs and bad outcomes, partly because of our own immune system's response to the virus.
Okay. Dr. Bebo, Collazo, the next question is for you. If you have survived COVID-19, is the person protected against future infection?
That's a great question. And the answer is that we don't know yet. And let me qualify that a little bit. We know that there's some early experience in some studies. There's an animal study that was done with macaque monkeys where they started to see antibodies being formed on day 14, day 21, day 28, and then they re-challenged these people the monkeys with the COVID virus, and they developed a short spike, a fever, and then it went away, and they never redeveloped the illness that they had during the first week or so. And so there is hope that there is, and some other data that suggests that there is at least a short-term immunity with the presence of antibodies. And so, and we're counting on that in terms of the concept of convalescent plasma treatment. Long-term, we don't know, because long-term that immunity may wane. There may be mutations of the virus over time if this thing keeps coming back the way influenza mutates. That's why the influenza vaccine is not 100%, far from it in most years, but it's better than zero. But time is going to tell, but there is evidence and that in the short run, we may have some immunity from developing antibodies to the virus.
I think that just to follow up on that, the model for what we think SARS COVID-19 is going to do is based on the original SARS outbreak, which was a different coronavirus. But it seemed that people who survived that infection were immune for about 2 years. So we're hoping that this will follow that same path. But we don't know. And we will find out as more people get better.
Yeah, I guess we all will. Thank you, Dr. Dowdy. This next question, I think this next question is Dr. Capote especially, but I think this is very important among young people today, especially some of our teenagers. Are people who smoke or vape at a higher risk? Dr. Capote.
Yeah, so we don't know, right? It's kind of the answer of the night that we really don't have a lot of information. It's all new. We're all kind of just figuring it out as we go and really just communicating. Initially, actually, it's funny. I was reading something about this earlier today, and I was having a discussion, and somebody said that actually there was some correlation that you might actually be protected. And don't kill me for saying that. I don't believe that at all. I remember when e-cigarettes first came out. I just started my fellowship, and they were checking inflammatory markers and exhalation called fractional excretion of nitric oxide. Anyways, and they noticed an increase in this. So I was like, wow, this is going to be interesting. What happens in 10 to 15 years if this is going to be a lot worse than cigarettes or just equally as bad? And right before the COVID pandemic, we were just in this big conversation of young people dying or having these bad, I guess, influenza, and there was a correlation with these cigarettes, and they were talking about the vitamin E in it and all this stuff. So I would probably say just avoid it. It does make Swiss cheese out of your lungs. It doesn't do good things to you. Just avoid it. As far as in terms of COVID-19, we don't know. But I would probably put it in the same category as ibuprofen. Don't use it. We don't know, but don't use it.
Yeah, I think that's good advice just across the board for everybody. Next question from one of our audience members comes from Andres Mendoza. If a child or adult tests positive for COVID-19, how many days from the break of fever can the person return to work or school? Any of you?
Well, the CDC recommendation is that when somebody who was tested COVID positive develops illness and starts to improve, that they should have 3 days of having no fever in the absence of any medication to lower their fever. So you have to have no fever without having taken anything, no Tylenol, no Advil, nothing like that. Additionally, there have to have been 7 days from the onset of symptoms. And at that point, if you're symptom free, you're not only no fever, your symptoms have resolved. The CDC actually says have improved. And I tell people your symptoms have resolved, because we also know that we test some of these people out further and further well beyond 7 days from symptom onset. And we're finding that some of them still have positive viral loads in their nasal pharyngeal passages. So to me, we don't know if the presence of the viral load in the nasal passage necessarily conveys infectivity. That virus may be wiped out and no longer active, but it's not worth taking a chance. So I tell people 7 days is what they say. If you've got to go back to work, you need to protect yourself. Protect other people and use masks and whatever other kind of distancing while you're back at work. But that's what the CDC says. I personally feel it could probably be a little bit longer, but that's the current recommendation.
Okay. This next question is for Dr. Mendoza. Is it true that the CDC, this question comes from Nicholas Caballero, is it true that the CDC has required hospitals/doctors to code or diagnose every patient that go to the emergency room with any kind of flu symptoms with a COVID-19 diagnosis code?
Not to my knowledge. No, the CDC is not requiring that. What the CDC does require, or what we report, are visits for influenza-like illness. So we may have suspicions of COVID, especially if they had an exposure or a pneumonia on X-ray, and we may code it, as either COVID suspected or influenza-like illness. It's interesting that so that's what the CDC tracks. That's what Miami-Dade Public Health tracks. We get the report every Monday. I get the report from the county health department. And for a couple of weeks before, in January, we were seeing really increased influenza-like illness. Now, influenza-like means not influenza, means a illness that causes myalgias or aches and pains, respiratory symptoms, some reason why the patient might think they have the flu. Interesting enough, a couple of weeks before, really COVID started exploding in our scene here, in January, we were seeing record levels of influenza-like illness in Miami-Dade County. There's some suspicion that it actually may have been coronavirus being circulating in our community. So, the CDC is here to collect data for us, and we really rely on them for epidemiological or, studying what happens with the disease process. So we actually do want to put in as a, it's not like a law. They're not, going to come and persecute us, or prosecute us rather, if we don't put it in. But most physicians who are suspecting COVID will put COVID-like illness in their diagnosis, and that will go back and feed back into the local health, county health departments, and into the state, and that will feed into larger databases about influenza-like illness.
There's a lot of codes that you can use that aren't COVID-19, such as COVID-19 suspected or COVID-19 exposure. Those are all different codes, and those are all codes that I'm sure that they're stratifying in terms of looking at this epidemiologically. And I will say that, to piggyback on Fernando's comment about all this influenza-like illness in January, early February in this town, is that there is that speculation about how many of those people might have been COVID-19. And this is where the value of antibody testing down the road is going to help, not only to determine if you're immune, but more importantly, to determine how much herd immunity we may have developed in our population. And as I'm sure Fernando is a herd immunity fan in terms of vaccines for children. But this is something that's critical for us to put a damper on this going forward, because this is not going to magically go away. And when it comes back, if we're more prepared and we have a certain amount of immunity, then we're going to be better. We're going to have better outcomes than we have right now.
That's good. The next question comes from Armando Rodriguez, and this is for all the sushi eaters like myself. Is it safe to eat raw sushi?
I guess I'll take that one. So the answer is, if you're thinking about COVID-19, eating raw sushi is safe, generally speaking. There are other things that people might acquire from eating raw fish, but COVID-19 is not one of them. So for the sushi lovers, I would say you are safe.
Okay. Next question from Maurice Visi for Dr. Capote. Any word on bedside bronching? I don't know if I'm pronouncing it right, Dr. Capote. Patients more or less with COVID-19.
So the guidelines, the original guidelines after the whole thing hit Seattle, were to avoid bronchoscopies because of the risk of aerosolizing the virus. I personally have done bronchs on some of these COVID-19 patients. I have to put on proper PPE, I have to wear the hood with a mask over, but it was a necessary procedure that had to be done at that time, 2 or 3 different times. But generally, routine bronchoscopies to collect samples are not common practice anymore, and specifically in COVID-19 patients, reserved for special cases. So the answer really is no. We're really trying to avoid doing it.
Okay. Next question is from Matt Panzer, class of 1998. What is the realistic time frame on a vaccine? I guess Dr. Gotti or if any of you want to.
Okay, so For the people who are not familiar with how vaccines get developed, you have something that you want to make a vaccine for. You have to identify where in the life cycle of that particular organism, a virus or a bacteria, you're going to try to make something that will cause the person's immune system to recognize this as being foreign and hopefully protect against it by building antibodies without actually getting the illness. So the steps are threefold. The first thing is you have to develop a vaccine and then trial it to see, is it safe? That means you'll take a bunch of healthy people, give them the vaccine, and then monitor those people very closely to see, do they have any bad side effects? Does somebody drop dead? Does somebody get liver disease? Does somebody have, a bad reaction of any kind? And that's step one. Once you make it to step one, then step two is, does the vaccine actually create the response that you want in the body? So if you're trying to make antibodies, which are the proteins that your body makes to help you fight off infection, do you create enough of these antibodies by administering the vaccine in a given individual? And then lastly, is it effective in a broad population? Can you manufacture it and give it to a lot of people and help protect those people from the disease that you're trying to prevent? So the timeline for that can be really long, and we don't know that vaccines are going to be successful. So the first thing is, if everything in a perfect world, maybe in a year and a half to 2 years, we may have a vaccine. But I'd just like to caution that by saying that we don't know too much about how all this is going to pan out. And HIV is something that we've been dealing with for 20 years. And I remember as a bright-eyed, bushy-tailed infectious disease fellow, we thought, oh, in 5 years, we're going to have a vaccine. Well, there have been numerous vaccine candidates for that particular virus over time, and none of them actually turned out to be very effective. Safe, yes, but not very effective. So I think we're hopeful that vaccine trials have already started. We're hoping that maybe by the end of the year, going into next year, certainly if there's another season of COVID-19, that there may be vaccines available at that time. But I think that it's a process, and there are no guarantees at this point.
Now, I will add to Dowdy's comment that going into next year, we're going to have a flu season. Flu doesn't stop just because COVID's around. And I would not, I would not avoid getting a flu vaccine for next season, even now, because you don't want to have COVID and flu. That'll wreak havoc on your body even worse. Again, go continue to get your flu vaccines, your seasonal flus. If you have flu vaccine, the other, especially for older people, the Prevnar or the Pneumovax vaccines, get your recommended vaccines. Don't avoid the pediatrician or your primary care physician or even your infectious disease doctor to get your vaccines, because you don't want to compound the problem by adding more infectious agents into your body.
So let me jump on that, Flash, and say that this is a perfect opportunity to remind everybody that influenza kills somewhere between 15,000 up to 70,000 people a year. I think in 2017 there was 70,000 deaths from influenza in the United States. The denominator is in the millions and millions. So the mortality rate is 0.1%. It's a very low mortality, but still it's a lot of people. So you should get your flu shot. This is an opportunity to remind yourself that everything you can do to protect yourself, be it exercise, eat right, get your flu shot. I think people say, well, who should get a flu shot? Everybody over 6 months of age should get a flu shot. Okay, everybody should get a flu shot. And even if the flu shot is only 20% effective, 15% effective, I believe in 2003 or 6, it was 90-something% effective, because it's a guess, you're chasing the mutation every year. But that's better than zero. And additionally, if you're over 65 or you have chronic illnesses, you should also be getting pneumonia vaccines. You should be getting your Pneumovax and maybe earlier on the Prevnar 13. Those are all things that you can do to protect yourself.
And just to piggyback off of that, that's one of the questions that I had. Can someone have the flu and the coronavirus at the same time?
The answer is yes. The answer is, it's certainly been described. And in our limited short experience here, I've experienced that where somebody came in and had, Dr. Mendoza mentioned human metapneumovirus, which is a different virus, another one that we have no medicine for, but the person had that and they had COVID-19, and that person then was very ill and ended up on a ventilator. So yes, we should be looking for all the things that we normally look for, and it's been mentioned before, but I think my fear is that in the anxiety that we all have about COVID-19, that we need to be vigilant, not just doctors, but people in general, that we don't put everything else aside and worry about that to the exclusion of everything else. So yes, you can have COVID-19 and some other thing. So
Wow.
stay protected with whatever you can get.
Next question from the audience is from Dati Milan. But why are certain blood types more susceptible to the virus, and are they more susceptible?
I think we don't know that. I mean, the Chinese experience, there are small literature that suggested that people who had blood type A may have had worse outcomes. But I think that there are population differences between the prevalence of certain blood types. So I think that I would not worry about that right now. I think that we shouldn't think that people who have type A blood are more likely to be ill from COVID-19. I think that remains to be seen whether or not that will play a role in how people do.
Okay. Next question is from one of our faculty members, from Beatrice Vincent. How does a serology test work, and does someone have to have presented symptoms to have this immunity? Mr. Gotti?
So serology is a shorthand way of looking at proteins in the blood that your body makes to help fight infection. So those are called antibodies. And Dr. Capote mentioned IVIG, which is basically immunoglobulins or proteins that can be protective against certain kinds of diseases that you get from one person, and in a transfusion give it to somebody else. So we don't know whether or not the antibodies that are produced in response to COVID-19 will actually protect people against being infected next month or next year. We're hoping to identify that, and antibodies again are protective in some diseases, and in some diseases they are not. So it remains to be seen whether COVID-19 will be one of those diseases where antibodies are actually protective. So serology is just a way of measuring antibodies, and right now we don't have a broad way of doing that for the population. Hopefully that will come, and that's part of the testing mechanism that will be ramping up over the next, hopefully, month or so.
And just to add to that, on Betty's question is, yes, if you have had no symptoms, it is very possible that you've been infected and have developed antibodies. The problem is that we're not testing a lot of asymptomatic patients unless they happen to have a definitive contact with a famous person, and then they get tested and they turn out to be positive. Actually, one of my one blood patients is that scenario. But absolutely, those people can be antibody positive, and maybe something further should be looked at in terms of why those people don't develop illness, in terms of the qualitative aspects of their serology that may be even more beneficial.
And let me ask you guys a question, something that I keep hearing a lot, and it's a question from one of the audience members. Does the warm weather have any effect on the COVID-19 here in South Florida? Is there anything that's been looked at other places with warm weather that affected it, that's going to kill the virus or make it less dangerous?
Well, if we look at where COVID-19 developed in China, it spread to many other countries, including countries where the weather is actually quite warm. So I don't know that we can be I don't know that we can depend on warm weather. Some viruses clearly have a seasonality, and the warm weather aspect typically has to do with the fact that when it's cold, people stay inside more. But Florida is kind of an anomaly because it's hot outside, but we go from our air-conditioned homes to our air-conditioned offices to our air-conditioned cars. So we're not really necessarily spending a lot of time outside in normal circumstances. We don't know much about whether this is going to be seasonal or not. And certainly, like I said, they have had outbreaks in places that are quite hot. So I don't think there's any, I don't think that we can depend on that as a way of saving us from the spread of disease.
All right, we got two more questions. The next one's for Dr. Bebo Collazo, for one of your classmates, Ernie Prieto. Dr. Collazo, stem cell therapy seems to be the possible future treatment of many medical conditions and diseases. Do you think stem cell therapy can be effective treating COVID-19?
You know, I knew he would ask me a question like that. I don't think there's no evidence for that, none whatsoever. I'm not sure if Jerry or Lorraine or Fernando have any. I don't know that anybody's looked at that.
Well, somebody funny that should come up because we are literally scouring all areas of medicine to come up with ways to combat COVID-19. And University of Miami, one of the researchers at University of Miami who's been involved in islet cell transplants has announced that they're going to do a stem cell trial to combat COVID-19. So the answer is we don't know. Hopefully, with some as this goes on, maybe stem cell may turn out to be a helpful modality. But everything right now for treatment, except for the things that Dr. Capote and the intensivists do, helping the person to breathe, helping them not to get infections on our part that would compound having COVID-19, and just trying to not add extra harm. We are literally casting about looking for things that we can do specific to the virus. So will stem cell be ultimately one of those things? We will find out.
Thank you for that question, Ernie.
Dr. Dowdy, you nailed it.
Copay on your next visit, by the way.
And then our last question.
Flash. Let me interrupt, Dr. Dowdy. You nailed it with the stem cells because I did hear that as well. Interesting enough, when they do give stem cells, and it started off with Joshua here at UM, they were giving it to the subclavian vein, and their first pass is actually the lungs. So it can actually maybe regenerate lung tissue. We don't know. But it is interesting, and it's awesome that you knew that too, because I just heard the same thing today.
You see, Flash, it's not easy being the second best doctor in the house.
All right. Last question comes from Blythe, and I'm not going to even attempt to pronounce your last name because I know I'm going to kill it. So he wants to know, but what are the, and I'm guessing to any of you, what are the ethics when it comes to testing? Is this considered moral? Are people compensated, or is this the promise of a chance to be immune enough for people? That's another loaded question.
I don't know if I understand.
Yeah, I don't understand the question.
Testing. If you're talking about vaccine testing, I think that's something that people will volunteer. These are voluntary, volunteers that show up for these vaccine studies. I think that might be referring to that. Is it ethical? Is it moral? All these studies are done with IRBs, institution review boards, and ethics committees. So nobody's being forced to participate in any kind of vaccine study. Dr. Dowdy, you want to comment on that a little more?
Well, again, I'm not sure I understood the question completely, but if the question is for antibody studies, again, these blood is taken from healthy volunteers, and that's one of the ways that companies might use to try to determine who may have had the disease and people who may be eligible to donate blood or plasma. So you already mentioned that nobody's going to be forced into doing anything, and people are always given the opportunity to opt in or opt out of any treatment or any studies.
You know, one of the essential rights of healthcare in the United States is informed consent. And so you're signing anytime you either participate in a study or offered testing, whether in an emergency room or a primary care office, or you're signing informed consent that I know what's happening. I'm allowing this to happen to me. So nobody's forced to do that. That's the you know, one of the solid tenets of healthcare in this country.
Okay. Yes, so that was our last question. I really want to thank all four of you. I know you guys are working long and for hard hours. For those of you out there don't know, I know Dr. Capote is in the ICU constantly with patients. Dr. Mendoza is constantly, you know, he's the head of the emergency room of Baptist for the pediatrics. He's really, really busy. Dr. Lorraine is in the middle of all this and Dr. Bebo was also really involved with all this. So I want to really thank you on behalf of the president of Columbus and all of Columbus for participating in this. We have planned for this to go an hour and a half at the most, went a little bit longer, but I think it was a lot of good. I think people asked a lot of questions. We got a lot more questions asked from the audience, which is great. So I really want to thank you guys. And I think this is very important for us as explorers to show the brotherhood and to demonstrate how sticking together, but we can rise up together. And like I always say at the end of everything we do at Columbus, gentlemen, adelante. Thank you.
Adelante.
Adelante. Thank you.
Adelante.
Adelante. Thank you.